And we all know that patient data shows immediate promise, and we just heard that it also poses new challenges. After all, it's filled with sensitive information. So last year, the Centers for Medicare and Medicaid Services created the Office of Enterprise and Data Analytics to devise a secure way to store data and improve care. And here to talk about it is Niall Brennan, the Center's Director and Chief Data Officer. And welcome, Niall. And back on the stage with you, Steve Clemons.
We were going to get somebody new, but sorry. Niall, thanks for joining. Wasn't that a fun session? I mean, that was interesting. This is a nice-sized room, so I hope that we're going to have a little chat, but I really would love to hear from some of you your thoughts about this. I mean, these are human stories. Many of you are in this business. I was just joking. You know, it's a Tuesday morning. It's sort of early, and this is your kind of crowd. Or, it's Wednesday.
It's been one of those weeks.
Yes, but, you know, there are data nerds out there, people that hear the word data and they get so excited, and you're one of them. Like, you're like the big leader. You're sort of, I was telling you when we were talking to Niall on the phone that, you know, there's some people I've met in my life that are sort of geniuses. They sort of swim differently. And Alan Greenspan used to sit in his bathtub with reams and reams of data, and then come out with he would go through reams and reams of stuff would fall on the thing. And I remember, I was one time at John Maynard Keynes's original apartments at King's College at Cambridge, and there was his bathtub, and I heard that he dreamed up the global economic system in his bathtub, so I took pictures of other people in his bathtub saying, this is where it happened. But
do you want me to tell you what I do in my bathtub?
I don't want to know what you do in your bathtub. I do want you to tell us that you're I sort of have done a lot of, you're sort of like the Keanu Reeves of the health data world, right? So, the Matrix. So tell us about your life in the Matrix and what it means for all of us.
Well, so first of all, we've had Alan Greenspan, J.M. Keynes, and Keanu Reeves in the first 2 minutes of this talk.
Does that make you feel good or bad?
All downhill from here. So I definitely am very passionate about data. I think I've been able to occupy a unique position over the past few years as the Affordable Care Act has become a reality, both from a legislative and implementation point of view. And I think one of the things is, with the passage of the Affordable Care Act, it just became clearer and clearer, I think, to CMS and the health care ecosystem as a whole, the critical and core importance of data to help us drive our aims and achieve our goals. So I do have a lot of fun. My friends call me the Nerd King, and to be at CMS, which sits on so much data that can drive actionable change, so we can understand better as a major payer what programs are working, what programs aren't working, so we can get the proper information to providers to allow them to transform the way they provide care. And then also several of the previous panelists commented on the need for greater patient activation and greater patient engagement, and we're exploring fun new ways to get patients the data they need as well.
So you sit on a ton of data. A ton of data has always been out there. Mm-hmm. That's not new. What is new are Bill Joy wrote years ago about how massive changes in computing power, massive changes in algorithms that can help us weave through this massively different on-roads and interfaces with apps and people and institutions. So that's the changing environment. And I'd love to get a sense of you of what's going well in that innovative environment and what's not going in the right direction.
So you're absolutely right. There are things that we can do today that would have been difficult to do or unimaginable even 5 years ago. We're providing secure virtual access to Medicare data via our virtual research data center to researchers all over the country, and so that just really expands the ability of people to look at the data, build insights. I think also from a technological perspective, everything is just happening quicker, faster. We've solved a lot of problems, again, on the Medicare side in terms of linking people across settings, across times to create a truly patient-centered, longitudinal view that can really inform care and research. In terms of the challenges, I think not all our data sources are perhaps in the way we'd like to see them. I think we have a little bit of ways to go with the Medicaid program to get Medicaid data to be as timely and valid. And that's a hugely important segment of the population. With the health insurance marketplaces, I think there were, some, documented issues with the launch of the website, but we've really got those very much under control. And now our challenge is harnessing a lot of that operational data and using it to build the most efficiently operating marketplace we can, while again giving patients and consumers the information they need to select the best plan, whether it's information on the types of drugs that they take or the physicians that they like to see.
So I may have this wrong, and I apologize if I do, but one of the things that I was reading about CMS data coming out is it began to flush out great price disparities and stuff. So you could be across town and have one set of treatments ascribed, and you could go over somewhere and be 3 times more expensive in one place. How is the reaction? Have you done a TikTok of one of the cases in which the revelation of that sort of pricing data publicly has changed the game?
So, we've aggressively embraced, the President's Open Data Challenge and the Open Data Movement. We're active participants with Chris and other folks in the Health Data Consortium. So the release of our provider utilization and charge data was, really a little bit of a revelation to us. We started a couple of years ago with hospital charge data, which I think is what you're referring to, and it did highlight the massive variations in charges in the same geographic area for the same procedure. So I think for us the most interesting thing was, as the Medicare program, we actually don't pay charges. We negotiate a rate with hospitals, so we're kind of paying them the same. But I think it was important to get that information out there, because for folks in high deductible plans or without insurance, they're not playing with negotiated prices a lot of the time. So it is useful information for them to have. And then we followed it up with huge releases of information on how physicians both practice care in Medicare and prescribe drugs in Medicare. And really, from our perspective, again, it goes towards getting more information out there, getting better information out there. Prior to those releases, really the only information people had about their physician was, name, address, and what their friends said about them. And now we have, actual concrete data on how they practice care available for anybody to use in whatever way they would like.
Was fraud easier in an analog world than it is in a digital world?
I think so. We were definitely in a pay and chase model. It's part technology, it's part transparency. So from a fraud perspective, I think we've made great strides in moving from pay and chase towards more predictive analytics to catch the fraud, before or as it's happening, as opposed to 6 months later.
So transport is 5 years ahead. What is your world going to look like? What will you have delivered? What are your, great mountain objectives that you want to deliver for us after 5 years on your job?
Gosh, that's an interesting question, and
we were videotaping
a little scary. I'll lapse straight into incommunicative bureaucrat mode. So I think for me personally, the goal is the right data to the right people at the right time in the right format. And that, it's, a little possibly trite and oversimplified, but that really is the goal. We've taken a lot of steps in that direction. We are providing monthly patient-level claims feeds to accountable care organizations, which for the first time is allowing physicians in fee-for-service Medicare, even though it's under the accountable care framework, to see the whole patient and be able to practice patient-centered care. We're about to significantly change how we implement the Medicare Blue Button program, which allows.
Tell us about. I've never heard of Blue Button. Maybe this is again. I'm new to this, but what is Blue Button?
So Blue Button's really cool. It is a way for beneficiaries, patients, to electronically download a machine-readable version of their claims data, their hospital physician and their drug claims. So Blue Button has been around for a few years. It's another area where CMS and the federal government has led the way. And really, again, there was a lot of talk in the previous panel about patient engagement and converting, data on patients into information so it could activate them in positive ways. So we think that Blue Button holds incredible potential. Just, everyday examples that, people struggle with when, your kid is going to school or a camp and you want to find the vaccine information. It's usually a half-hour drive to the doctor, an hour wait in the doctor office, a 10-minute, transaction, and then back. That information should be available to us in electronic, in a friction-free form. We need to take a lot of the friction out of healthcare transactions and get information into people's hands. So with Blue Button, we want to tweak it. We want to make it more user-friendly and customer-friendly. We want to make it more friendly so that the patient can be at the center from a privacy perspective and designate the apps and the different types of value-added applications that they would like to send their data to, so that those apps can maximize the data in a way that engages the patient.
When you sort of look at the world you're in and data, have you always been a healthcare person?
I've always been a data geek and a healthcare person.
So data geeks are different than healthcare. Data geeks. So
I'm a healthcare data geek.
I've learned this recently that the people that are in it. How many of you consider yourself data geeks? Any? Yeah, there are a couple. So you guys just are wired differently, and I respect that. But it means that as you process information, as you think of engagement, you could go look at a children's park or the Pentagon or some education, the third year, and you're just processing things differently. And I'm interested. We recently met this guy from Google who's working with, I think it's called the National Autism Foundation or something of this sort, but he's the one who's really looking at how do you organize the information from all this genetic coding, and he's an expert in information management from Google. He's not an expert at all in autism. And so I'm interested in whether there are things that we can learn in the way data and information is organized that's distinct from, say, the health world.
Absolutely.
Does that make sense, that question?
Mostly.
Probably your data people may be bored with this, but it is interesting. Are we getting the organization of what we prioritize right? And I found that people that are those data geeks somehow see those things that many of us that are working in a different interface don't see.
Well, so I'm going to try and answer the question in a way that will hopefully make sense to you and other folks. I do think you have a point there, because one of the things that I have noticed over my 5 or 6 years at CMS and this kind of, grand experiment with data is there are lots of people who work with data, really, really smart people, but who cannot make that data meaningful to non-data users. And I think one of the successes that we've had, and this goes more to our internal analytics that we do for the administrator and the secretary as opposed to the external data releases, is that there is, I don't know, I think it's part art, it's part skill, but to wrangling billions and billions of records and distilling it into one slide or one picture that makes somebody go, wow. And doesn't just make somebody go, wow, but makes them, change how they do something. And so that's where I think that data people are different, where it's like really focusing in on the exact thing, the magic bullet, so to speak, the magic data bullet that will make people look at a problem in an entirely different way. And again, my goal is not just to create pretty pictures, it's to create pretty pictures that change the way healthcare is delivered in the United States.
That's exactly the answer I was looking for my inchoate question, so thank you. Another element that we've been talking about today are essentially the stakeholders in the discussion, how data, and by the very nature of how big a footprint you have, you're playing with everyone. You're playing with pharmaceutical companies, you're playing with hospitals, primary care providers, all of that. Who's rising to the challenge and who's not?
Well, we love all our stakeholders equally, so it would be very difficult for me to pick a favorite.
Can't blame you for trying.
No. It was a noble try. I think everybody's really stepping up to the plate, particularly on the provider side as we aggressively move towards alternative payment models, ACOs, primary care medical homes. I think providers are really embracing the fact that they have to, adopt, just looking more at data, data-driven care, et cetera. I think, even, pharmaceutical companies, other types of suppliers are starting to realize that, it just can't just be a here, pay for this, that there needs to be, much more rigor and I think, real world evidence behind, new treatments and applications.
The other element here, and I'm interested in how you do it, I was discussing privacy, and, in your world, you've got to think about it. How do you get the balance between how are you getting the balance right between privacy needs and the privacy concerns that people have and the sort of insights that you get from massive data? And what lessons for other players? Because I'm not sure how involved Medicare and Medicaid would be in this, but when you're looking at other stakeholders that are trying to get that balance right, what lessons can you convey?
So, I think the primary thing from a privacy perspective is I do actually believe that if people, play by the rules, it is possible to carve a path that can, leverage data to its fullest potential while absolutely respecting patient privacy. Patient privacy is obviously key to us because we directly or indirectly cover so many Americans. There was some conversation about HIPAA as a framework on the previous panel. I do actually believe, I would agree with some of the comments that HIPAA is occasionally misinterpreted. I think it provides a very robust and flexible framework that permits interesting things to happen with data while very much protecting patient privacy. And again, with efforts like Blue Button, we are hoping to start to begin to put the patient more in the center of decisions about how they would like and what they would like to do with their data.
Do you think the overuse of HIPAA coincides with commercial interests of those overusing HIPAA?
I'm really not sure. It's a complicated regulation, and I think it's just one of those things people see in HIPAA what they want to see in HIPAA. So,
but there's two answers in that. There's one answer. Thinking journalistically, there's one answer where the overuse of HIPAA is because they're very, very worried about patients' rights and information, and that's earnest, and you can applaud that and maybe evolve and find. There's another element where it says that's a point of structural corruption that you've got, and in a discussion, and to be quite honest. We were up in Cambridge one day working with Siemens, and we had doctors, out of the league of incredible medical centers up in the Boston-Cambridge area who were lamenting that there wasn't greater sharing between these institutions because those institutions saw great proprietary benefit in what they had. That was from them, not from me. And I said, wow. That's structural corruption in a way, a corruption of interests.
Yeah, and we're very committed to ending those types of practices. Obviously, there's been a lot of talk about interoperability of health information technology, and we have some pretty ambitious goals around there because I don't think we've made the progress that we've liked. And so, we do hear accusations of information blocking across vendors or systems, and we've actually set up a hotline, if you will, where people can report what they believe to be information blocking for the sake of information.
Before I go to the audience, I have to switch gears here for a minute. I read people's tweets, and you are a biking obsessive compulsive guy, a biking geek as well. And he writes, rocking my CMS Gov sweatband. Do you have a CMS Gov sweatband? Like that's a new level of geekiness. CMS Gov sweatband on an epic 72-mile, 8,000-foot elevation ride yesterday. You did that in one day?
Yeah, we rode the we rode Skyline
Yeah,
Drive.
72 miles in a day.
So
what
I actually
was
did a century
and
on
what
Saturday.
was the sweatband about?
Oh well, the sweatband is just in a way it's kind of funny. It's
Seems funny to you.
It's well because this is now going to sound kind of gross. It's a hand-me-down from an older CMS employee, but he assured me that he never used it, and it was just back in the pre-GSA days when federal government employees were allowed like little little tchotchkes.
Taking wearables to new levels.
And I'm not sure sweatbands are allowed anymore. So yes, it's a hand-me-down sweatband.
Okay, well, great. Well, I want to thank you for clarifying that. Let me open. Niall Brennan is here. Let me open up the question floor to others. Comment. Yes, right here in the front.
Hi, I'm Shauna Sandberg from the Center for Workforce Studies at the Association of American Medical Colleges. There is currently a concern in health policy circles about whether we'll have enough providers in the future as the U.S. population continues to grow older. But one of the big questions is whether these new care delivery models, new payment models, are actually making care more efficient to the extent that we'll be able to get by with the same number of providers in the future, whether we'll need more. What kind of data is CMS collecting about use of providers and use of the workforce in order to understand how we might make care more efficient?
Fascinating.
So it's a great question. I mean, I think we're aggressively evaluating all of the different demos and pilots that we have going on, and there's definitely a workforce component to that. We read the stories and are sensitive to concerns about the pipeline for doctors in particular, and I think definitely encourage the use of other qualified clinical personnel to try and build a more holistic approach to care delivery that doesn't necessarily require the doctor to be involved at every step. You don't want very, very highly trained physicians to be working doing tasks that are significantly below their pay grade.
Interesting. Yes, right here. Sorry, everyone, this is Lindsay Holloway, and I just enjoy sending her one room across the other. Yeah.
Sure. Dana Connors, I'm from the Electronic Data Methods Forum at Academy Health. And I'm thinking about the conversation that happened on the last panel about the burden on the patient. And it seems to me that we're all saying that we've had this data for a long time, but we need to do something different with it, or we need to utilize it now. So the first question is, how now or why now, right? Like what's different now that's going to help us do this? But it also occurs to me that part of what we're saying is that the burden needs to be on the patient, right? We have this system where we have providers who are engaging these multiple patients, but the patients if we're going to change the system, we're going to effectively graduate the system to the next level, those patients have to be engaged. And how are we going to do that?
So I think true, real, meaningful patient engagement is the million-dollar question, if you will. I think people have been trying very hard for a very long time. I think the imperative is, we have to do it. I think, delivery system reform alone and changing provider behavior, while really important, will only get us part of the way there. And so I think it's an evolving process. I do personally place great hope that giving people access to the right information, again, in a kind of a seamless or frictionless way, like, instead of making somebody go to a website and click through a bunch of different things, in some way, have the information pushed to people via smartphone or other device or wearable, et cetera, et cetera. Those are, I think, are the areas that we need to really push on over the next couple of years.
We're right near the end, but how many of you are doctors? Any doctors here? Okay, you're an exception to the rule, I'm just going to say here. So, what's that? Always, yes. So, but one of the things is when you ask this gentleman's question and you sort of look at this question of patient empowerment out there and what we're trying to achieve, what does data achieve? The Atlantic ran an article, I think it was something saying, please thank you for your patience or something, or the robot will see you now. But when you look at the changing technological terrain of medicine and health, I find this in teaching too, and I really tick off a lot of teachers. See, isn't the fact that what you're trying to do is both achieve efficiencies, but more predictability of outcomes. So one of the complaints is that doctor to doctor or patient to patient, you have variables. You have doctors like we were just discussing that someone wanted to wring their neck and then they would go find it. You also have patients of incredible different levels of literacy. And aren't the platforms that we're trying to create less dependent on those variables so that you get greater predictability of outcomes?
So, there's always going to be, a distribution of doctors and of patients. I don't think.
But shouldn't we expect to narrow it?
I think again, if yes, I think it will narrow because with the approach that we're taking to delivery system reform, it sort of will bring folks upwards, but also inwards. And I think again that as the information starts to flow more seamlessly to patients, they will embrace it more.
I saw a question, right here. So we're going to do 3 quickies and wrap up.
Yeah, hi, my name's Grady Four. In talking about, there's a lot of things in the system that make a direct advantage from the data and even can make a profit. Is there a better way to incentivize patient participation that's more direct than is currently going on?
Thank you. Patient participation.
Patient participation in their care journey, or?
Both in their care journey, but also in their willingness to provide data.
Yeah, so, I think...
You get their data because they want to get paid or get support, right? So that's an incentive.
So, yeah, CMS gets all the data because we're the payer. I think, people will point to numerous studies of patients that highlight that when it's explained to them what the data might be used for, the approval rates for sharing data are generally really quite high. I think you need to create, the key thing is creating a framework where they can have full assurance that their data won't be used for anything untoward, and particularly anything that could affect them in a personal way.
Real quick. And really quick. Okay.
Hi, I'm Michael Madoff from Young Invincibles. I think when we were building the healthcare exchanges and healthcare.gov, there was this great analogy that we're building the Amazon.com of getting your health insurance. Do you think there's a similar analogy to help explain to the public what we're doing with data and with Blue Button?
I'm not sure if I compare it to...
What was wrong with The Matrix and Keanu Reeves?
Again, it comes down to, and I've repeated the word a few times, but like creating a frictionless environment. Right now, getting information about your doctors or yourself is a oftentimes frustrating, lengthy, in many cases still paper-based experience. So yes, we want to bring the kind of seamless customer experience, whether you're a provider or a patient, to healthcare data that you get with Amazon.
Yes, right here.
I'm Daniela Stein with Insight Telepsychiatry. You mentioned that you haven't yet seen the interoperability in healthcare technology that you're hoping to see in the future. I was wondering what CMS is doing to get there. And I do think it's incredibly important for people who will never be able to access, for financial reasons, the personal health tracking data that we get with Fitbits and other expensive technology.
What are you doing to fix that problem?
CMS is doing what government does. We're writing a regulation, and that regulation will have lots of rules of the road around interoperability. But I think we're also taking a much more public stance, as evidenced by Andy Slavitt's keynote at HIMSS this year, that we really we're serious about interoperability. We're serious about stopping information blocking, and again, because of it all links together, right? Because of delivery system reform, we're creating an imperative for healthcare organizations to share information with each other. So it will come.
Great, right here. Nope.
Pratima Advani,
I gave a shot. Yeah, you can get up soon. I know you're ready to go, Margaret. So, yes, go ahead.
I know we've talked a lot about, and you said your goals are getting the right data to the right person at the right time. Predominantly right now, many of the programs are focused on the 5% that drive up 75, 80% of the cost. And granted, we need to focus on that. I'm wondering what your office is doing in parallel, potentially, to address the tsunami that follows, because you deal with this 5%, and then there's a bigger tsunami behind it, because you have the graying of America that will probably have a larger population driving up even a bigger piece of the cost.
Perfect.
So it's
Tell
kind
us
of
who you are.
I'm Pratima Advani, Avlier.
Great. Thank you.
What are we doing to kind of deal with the people that are right behind so that we prevent them even getting to that 5% that drive up 80% of costs?
Great question.
So that's something that I don't think you can do with data alone. There's I think a large role that clinical intervention and monitoring aided by data can do. We're sort of looking at all folks all the time, not just the 5%. But identifying who the next 5% is not entirely straightforward. But I do think that just the common sense, proper management for diabetics, other folks with chronic disease, and we can get there.
For being a chief data geek, you're a very nice guy and very smart. So, ladies and gentlemen, please thank Niall Brennan, Director and CMS Chief Data Officer at the Centers for Medicare and Medicaid Services. Thank you so much.
Thank you, Steve.
Thank you.
My pleasure.